Good morning, students. So, today's class we are going to study about heart rate variability. So, here nowadays, when you see people are initially getting collapsed, suddenly they get heart attack, and then at the fraction of seconds, if the CPR or any kind of first aid is not given, so they go to the extreme level of death or even coma also. So monitoring the heart rate is very important. So here when you see the heart rate, which is controlling the heart rate. So here we have a sympathetic and parasympathetic nervous system, which are the two one which controls the heart rate. When sympathetic nervous system increases the heart rate, this parasympathetic nervous system will bring back the heart rate to a normal value, normal range. So that's why in the heart, there is a sympathetic and parasympathetic nervous system which controls the heart rate. And if there is any rapid fluctuation in the heart rate, that is usually reflected in the peripheral nervous system control only. And if there is any changes in the heart rate over a time, um, so you can see this is due to the autonomic physiology or autonomic nervous system response. So we need to analyze the heart rate variability because it quantifies, this HRV quantifies these changes over time. And when you see this is a simple model of a cardiovascular system, it shows the modulation of heart rate by parasympathetic and sympathetic nervous system. So when you see the sympathetic nervous system, when you it triggers the heart rate and increases, when the heart rate increases, what will happen? The cardiac output and the blood pressure it also increases due to some renin-angiotensin system. So what will happen? Then the signal is sent to the parasympathetic nervous system. This will bring back the heart rate to a normal range. So this sympathetic and parasympathetic sympathetic nervous system, it is exists in as a feedback loop. And what are the influences on heart rate variability? There are certain extrinsic rhythms like our activity or sleep wake cycles, eating meals, or even mental stress or physical stress. These are the factors which influences the heart rate variability. And some of the influences on heart rate variability with respect to intrinsic period is that is internally how it's being affected due to the respiratory sinus arrhythmia or due to the baroreceptor reflex regulation or thermoregulation or neuroendocrine secretions or sleep stages during the night. So the circadian rhythm. So these are some of the factors in which intrinsically it will influence the heart rate and heart rate will increase. And now, what are the quantifying parameters? Quantifying methods are available. Approaches are available for this heart rate variability. The first approach is the physiologist paradigm. So here the heart rate is data. It is collected over a short period of time, around 5 to 20 minutes interval, and then carefully they observed in the controlled laboratory conditions. Second approach is the clinicians and epidemiologist paradigm. According to that, they will collect the heart rate for a period of 24 hours or less and usually on the outpatients and analyze the signal. And approach time. One, how much variability is there? How do we measure those variability? There are different methods are available. One is time domain and geometric analysis. Another approach is frequency domain analysis. These are the two different methods available to analyze the heart rate variability. So one by one we are going to explore now. So in this frequency domain analysis, we'll see what are the underlying rhythms, what physiological process do they represent, how much power does each underlying rhythms has. So these can be analyzed in frequency domain analysis. And in third case, how much complexity of self-similarity is there that can be estimated by nonlinear analysis. Now let us see the time domain HRV. So here it is calculated from the normal, for in a ECG signal, one cycle is there from normal R to R interval, we call it as N to N interval. So from one cycle of R to the next cycle of R, we call it as R to R interval. To that interval, now let us see that this R to R interval, we are calling it as interbeat N to N intervals. So in this particular interval, we are calculating certain parameters. Those parameters are the first one we call it as SDNN, which is the standard deviation of N to N interval in terms of milliseconds. So that is called total HRV. So within that heart rate variability signal, there are so many cycles will be there. To each cycle, we'll be calculating the standard deviation. That means how much deviations it is provided from the mean value. Then SDANN is standard deviation of 5 minutes mean value of n to n for each 5-minute interval. So this we call it as circadian HRV. So both SDNN and SDANN both reflects the longer term HRV. Then the next approach is SDNN-IDX. So here also they calculate the average of standard deviation of n to n for each 5-minute interval in terms of milliseconds. So here it will combine the response of sympathetic nervous system as well as the parasympathetic. You know that the sympathetic one will increase the heart rate, parasympathetic bring back the heart rate to a normal place, normal state. So this reflects the intermediate term HRV. Then we have a average n to n, average of n to n interval, which is measured in milliseconds. So you can able to calculate the heart rate by the formula 60,000 divided by average n to n. This will give you the heart rate. Now, the next parameter is calculated from the difference between the successive n-to-n intervals. So that is based on two parameters. One is RMSSD and PNN50. RMSSD is a root mean square of successive difference of the n-to-n interval. That means to one cycle of R wave to the another cycle of R wave. So in that they obtain the root mean square of the difference between that signal. And like that PNN50 is the percentage of successive n-to-n difference should be greater than 50 milliseconds. So that is called PNN50. That is another parameter. So this RMSSD and PNN50, we call it as short-term HRV, and it reflects the parasympathetic influence on the heart rate. Now the frequency domain HRV. The frequency domain, it is mostly based on autoregressive technique or sparse Fourier transform. And here the partitioning the total variance in the heart rate into underlying rhythms. So it will occur at different frequencies. Now, what are the underlying rhythms? So you can able to see you have a sinusoidal signal. One rhythm means one cycle. You can see it is 0.5 seconds, just 5 seconds. So how many cycles are there in this from 0 to 60? When you count the number of cycles, it is 12 times per minute. Okay, this is 1 minute is 60 seconds, so it is 12 times per minute. Now, second signal, it is we are taking the FFT of it. So when you take the FFT of it, it will determine 5 seconds cycle is 1 by 5 cycle per second. That means T equal to 1 by F. Okay, or F equal to 1 by T. According to that, when you substitute 1 by 5, it is 0.2 Hertz. In terms of frequency, when you express, we can express the same signal in terms of frequency term like this. That is 1 by 5 seconds, which is 0.2 Hertz. Now the next signal. We have three different signals are mixed up here. So those are high frequency signal and low frequency signal and very low frequency. The third one is very low frequency signal. And if you see the high frequency signal, you can count the number of cycles. Number of cycles when you count it is 15 cycles. So 1 by 15 it is around 0.25 Hertz. And low frequency signal when you count it, it is 6 only. 1, 2, 3, 4, 5, 6 only. So again 1 by 6, one cycle when you count it is 0.1 Hertz. And very low frequency again only one cycle is there. So if you apply it is 0.016 Hertz. So in this way we can able to differentiate the three different rhythms. And if you see when you add all these things, because each waveforms are different amplitude, when you add it you will be having the signal like this. And when you take the frequency of it, so one will be very low frequency, then low frequency and high frequency. This is the signal we will be getting it. So what are the underlying rhythms in the heart rate signal? First is high frequency band. So at the frequencies ranges from respiratory frequency ranges from 9 to 24 cycles per minute. It's high frequency band. Here the peripheral nervous system will influences on the heart rate. Then we have low frequency band or the frequency respiratory frequency between 8 to 10 second frequency. We call it as low frequency band. Here the baroreceptor, sympathetic nervous system, parasympathetic nervous system influences on the heart rate. Then we have another two frequency signal, which is very low frequency band, which is called as VLF. So here at every 20 seconds or every 5 minutes, we are measuring the signal. So it reflects the vasomotor changes thermoregulatory, and the peripheral nervous system will influence the heart rate. And ultra low frequency band, which is called as ULF, at every greater than 5 minutes to once in 24 hours, this signal is being measured. It reflects the neuroendocrine activity and other unknown rhythms. So this is an FFT of a 24-hour average of 2-minute power spectral density of a healthy adult. You can able to see here the low frequency peak and high frequency peaks here. And non-linear HRV. Non-linear HRV, it's characterized the structure of the heart rate time series. Here the randomness, increased randomness of the heart rate time series, it is associated with worse outcomes in cardiac patients. So we have to be very much careful in estimating the heart rate. The most commonly used measure of randomness is called short-term fractal scaling component. We call it as DFA1. When there is a decreased DFA1, it will increase the randomness of the HR. Okay. And the normal DFA1 range is 1.1. If it is less than 0.85, it is high, associated with high risk. And here, this is a comparison of a normal and highly random HRV plots. And what is the clinical correlates of decreased HRV? Why there is a decreased HRV due to inducible ventricular tachycardia or ventricular fibrillation? For these conditions, there is a decreased heart rate, and due to the risk of sudden cardiac death or increased mortality post myocardial infarctions, and due to the congestive heart failure or poor survival in chronic disease. There is CHF, there is congestive heart failure, and COPD is chronic obstructive pulmonary disease. For all these cases, there is a decreased HRV. So the HRV should not be too much decreased, should not be too much increased also. So both leads to a severe problem. And what is the clinical correlates of decreased HRV? It is maybe due to the diabetic neuropathy, or when the patient is suffering from alcoholic neuropathy, or post-cardiac transplant, or depressions, when there is susceptibility to SIDS, poor survival in premature babies, increased mortality in population studies. For all these cases, there is a decreased HRV will be there. And what are the pitfalls in understanding the HRV? So the HRV reflects the phasic but not the tonic modulation of HR, and we cannot able to measure the autonomic tone here. And this HRV is often considered as a black box because the decreased HRV means we have decreased autonomic input and decreased cardiac response. So that's why HRV cutoff points for risk has been established in immediate post myocardial infarction period. And here, in case of athletes, for the sports people, there will be high HRV, but we cannot estimate that they'll have very high heart rate. It's abnormal case because when the people do exercise, there will be a increased HRV. In that case, we cannot say that it is a kind of abnormal. So HRV can sometimes exaggerated or increased by randomness. So it is not truly normal, but it appears despite the normal appearance of ECG. And what are the clinical implications of HRV? So normal HRV is a good negative risk stratifier. When the patient is preserved HRV is SDNN greater than 100, they are at low risk in the absence of other significant risk factors. And when they estimate the sensitivity and specificity of the decreased HRV, so here they identify the factor that SDNN is less than 70 milliseconds for immediate post myocardial infarction. So in that post myocardial infarction, SDNN estimated to less than 70 milliseconds. So that is very much, it's a kind of an abnormal one. And how can the HRV be increased? Due to medications like beta blockers, AC acetylcholine inhibitors in congestive heart failure, like that, and ventricular resynchronization therapy, cardiac rehab. So these are the certain things in which we can able to increase the heart rate when it is being decreased. And another way how we can able to increase the heart rate due to lifestyle modifications like smoking, weight loss, exercise, stress management, lipid lowering level, and glycemic control. All these things will make the HRV be increased. And final thoughts about HRV is it's a non-invasive method for identifying the abnormalities in cardiac autonomic modulation. And the decreased HRV sometimes it causes the decreased heart activity and heart failure. So HRV in combination with other risk stratifiers, it will improve the risk stratification also. So HRV should not be too low or should not be too high. It should be maintained at a certain level. And normal HRV identifies the patients at lower risk for events. And HRV cutoff points are very population specific. And it now appears the decreased HRV and increased randomness of HRV. Both are independently associated with high risk. So thank you all of you for watching.